Okay, so Assalamu alaikum everyone. My name is Rawad Turko. I'm a second year medical student, and today, inshallah, I'll be teaching you about the electrocardiogram. So for everybody who was in pre-med, I taught this before in pre-med, and I said the same thing then that I'm going to say now. It might seem like a difficult concept at first. It might seem like a difficult lecture at first, but actually, whatever you learn here, you will learn more about it in the upcoming lectures. So I'm sure you guys took cardiac cycle by now, right? Am I right?
Yes, we have.
Yeah. So did you guys find that it had a few connected ideas between ECG and the cardiac cycle? There were a few connected ideas.
Yes.
Yeah. So that's what I mean. So you'll learn this lecture. You'll do your first study of this lecture. Maybe you won't grasp every single concept, but you'll definitely be able to do it better in the further you go in this block, inshallah. So with that being said, let's get started. So here are the objectives for today. Okay, we'll be talking about we'll be talking about the principles of measuring ECG in the three limb leads, and we're going to be introducing Einthoven's triangle. We're going to be explaining how the electrical activity spreads through the heart and then link it with the mechanical events of the cardiac cycle. We're going to explain the events and the intervals of the ECG itself. Then we're going to discuss the 12 leads, and finally, we're going to explain how to determine certain parameters from ECG. Mainly, we're going to talk about heart rate. So with Shams, inshallah, you guys will be doing ECG2 with her, the arrhythmias, and she'll be teaching you more about different aspects of the ECG and some arrhythmias. So this is just for ECG1. So just like every other thing that we learn in medicine, we're going to be breaking down the word. So what does the word ECG mean? Well, it stands for electrocardiogram. So if we take that big, connected jumble of a word, we're going to break it down into three pieces. We're going to break it down to electro, cardio, and gram. Electro obviously means electric. Cardio obviously means hearts, so cardiovascular, hearts. Gram, to record. So easily put, electrocardiogram, it's a recording of the heart's electrical activity. So as we know probably from your electrophysiology lecture, your heart's constantly being depolarized and then repolarized. So there's a lot of electrical activity going through it at any given time. That's what we're trying to measure with the ECG. Okay, so do a quick refresher. So depolarization of cardiac tissue leads to the action potential and thus contraction of the heart. So depolarization happens and then you get contraction of the heart. Okay, so the electrical activity precedes the mechanical activity always of the heart. So depolarization and then contraction. Or in other words, you could also say repolarization and then, can anybody tell me what comes after repolarization? So depolarization would lead to contraction. Repolarization would lead to, anyone know? Okay.
Relaxing.
Relaxation, yes, perfect. Thank you so much. Yeah, relaxation. Okay, so the electrical activity precedes the mechanical activity. Again, you might be asking me, well, okay, we know that, for example, we know that the pacemaker of the heart is the SA node. Okay, so the SA node is just a jumble of cells. How does that one jumble of cells, the electrical activity just from that one spot, translate and go and move through the entire heart? Well, that's because our cardiac muscle cells are coupled by gap junctions, which are these tiny little holes that connect cells in which the electrical activity can flow. Okay, so this one cell is going to get depolarized, and then the next one, then the next one. Let's put that into some visualization. So just look at this diagram right here. I'm going to move this thing over here. Let's look at this diagram of the heart, and let's zoom into one aspect, one part of the heart. Okay, it doesn't matter where we go. Let's just go there. Okay, and let's look at these cardiac, by the way, these little circles, they're cardiac muscle cells, and let's line them up together. Now, let's say, I can't really point because this is Canva, but let's say I depolarize this first cardiac muscle cell in this lineup. I depolarize it. I take a little taser and I just I zap this first one. What's going to happen to the next one? What do you guys think? I'm sorry?
It will gonna depolarize.
Exactly, yes. So you depolarize the first one, the second one's going to get depolarized, so is the third one, and the fourth one, and the fifth one, and so on. Okay, so that's how the electrical activity spreads through the heart, through these little gap junctions that are coupled in the cardiac muscle cells. Okay, so how do we measure this? We want to measure this activity as it's going through the heart, as it's going up, as it's going whichever way in the heart. We want to measure this activity. How can we do that? The ECG. Okay, but let's get more specific. So I don't know if you guys paid attention back in high school physics, but there's something that we like to call a voltmeter, okay, or a galvanometer. That's another way of saying it. And a voltmeter, basically, you don't have to know this stuff. It's just for your a better understanding of it. And a voltmeter is a device that connects the potential difference through the circuit, or basically it records the electrical activity through a circuit. So that's pretty much what an ECG is. And the way we do that is that we take a negative electrode and a positive electrode, and we put them on either side of this little lineup of of cardiac muscle cells. We put an electrode here, as you see, and electrode here and an electrode here, a cathode here and an anode here, and you measure the electrical activity as it's moving through this lineup of cardiac muscle cells. Now, the physics of it, you really don't have to get into. You really don't need to get into. All you have to know is that the ECG is a voltmeter, okay, and we record the electrical activity of the heart by using these little electrodes that we place on our body. Okay, so now we looked at this lineup of cardiac muscle cells. Now we can zoom out and look at the entire heart. And instead of putting an electrode on either side of this lineup of cardiac muscle cells, we could put an electrode on either side of the entire heart as it is, and we can measure the electrical activity as it's going through the entire heart and not just through this little section. So, principles of the ECG. Oh, sorry again, I'm going to keep doing that probably. An ECG machine, as we said, it records the electrical activity of the heart. A depolarization, or in other words, what would cause a contraction. A depolarization, by the way, is when these negative charges turn positive. So we know that the resting membrane potential of a cell, any cell, usually is negative. A depolarization, if you guys remember from your previous lectures in foundation and in CVP, actually, a depolarization is when that little membrane potential becomes more positive. Okay, and those negative charges turn more positive. So a depolarization traveling towards the positive electrode gives a positive deflection on the ECG. Okay, so let's again look at the diagram. So look at this little thing that we set up. We put an electrode, a negative electrode here, like on this side. I don't know how to point at the screen, and a positive electrode on this side. Okay, so if we have a positive wave or a depolarization wave moving from the negative electrode to the positive electrode, that's going to be recorded as a positive deflection on the ECG, meaning an up-down. Okay, so on the ECG, it's going to look like this, an up and a down, pretty much like this. Okay, so that's the first example that we just gave. Okay, so look at the top left corner of the screen. You see that's exactly what we just described. We see a depolarization moving towards the positive electrode. And if you look right below the diagram, you see a positive deflection. Okay, so that's what it would look like on an ECG. Now look at the one beneath it, still bottom left. Now we see a repolarization. A repolarization, again, like one of the students mentioned here, it's relaxation. So a repolarization moving towards the positive electrode would give you a negative deflection. And again, we have 4 cases. The fourth one, or the third one, sorry, top right this time. A positive electrode, so again, a depolarization moving away from the positive electrode, or in other words, towards the negative electrode, again, will be a negative deflection. And finally, a repolarization or negative charges moving towards the negative electrode will give you a positive deflection. Now, this all might seem like a bit, a bit much. No, I have to remember that this goes here and this does this shape. And I get that it's a bit much to memorize, and nobody likes memorizing. I'm sure I don't like memorizing at all. So what I like to do is come up with a simple little sentence, just something that I remember. And just from this one sentence, I'm able to remember every single case. And that what I want you to remember is like charges towards the like electrode will give you a positive deflection. So like towards like, meaning positive towards positive or negative towards negative. So as we see here, top left again, positive charges, which is a depolarization towards the positive electrode, positive deflection. Positive towards positive, positive deflection. Now, bottom right, negative charges, repolarization towards the negative electrode, positive deflection. Okay, like towards like, positive towards positive is positive, negative towards negative is negative or positive. Does that make sense to anyone? Does anyone have any problem with that so far?
So I have a question.
Yes.
When cell become depolarized, so inside it's gonna be positive or outside?
Inside is going to be positive. It's the membrane that's going to be.
So normally inside will be, normally inside is negative.
Well,
When depolarized, will become positive.
Yes, yes.
Okay.
We're talking about the membrane potential. So we're talking specifically about the membrane. Okay, but yes, it could apply to the actual cell itself. Okay, now with these tiny little details, they usually don't bring a lot of questions on these tiny little details, at least not in CVP. That would sort of be more of a foundation type question. In CVP, though, they're going to be focused more on your arrhythmias and on your basic ECG stuff. So they'll tell you like what is the QRS complex corresponded to on an ECG. So it'll be more broad questions like that rather than those little tiny details. This is just for you guys to build that idea in your head. Okay, so again, I'm going to just reiterate one last time. Like charges towards the like electrode will give you a positive deflection. Anything else is a negative deflection. So positive towards negative is a negative deflection. Negative towards positive is a negative deflection too. Okay, so again, depolarization towards the negative electrode, or in other words, away from the positive electrode, will give you a negative deflection. That's our top right. And for our bottom left, the negative charges or a repolarization going towards the positive electrode, again, will give you a negative deflection. Okay, checkpoint 1. I know we're gonna be moving just a little bit fast. Does anybody have any questions for me up until this point? Aside from the one that we just got. Okay, I'm gonna take that as a no. By the way, guys, feel free, don't wait for me to stop talking or to take a checkpoint to ask me any questions, okay? So ask me any questions as soon as one pops in your mind, okay? So since you guys don't have any questions, I'm gonna ask you a question of my own. I really, really need your participation with this, guys. Please bear with me. Okay, pop quiz. A depolarization moving away from the positive electrode will produce which shape on, oh, sorry about that. Okay, you guys didn't see that. A depolarization moving away from the positive electrode will produce which shape on the ECG trace?
Negative.
Okay, negative deflection. You answered that a bit too fast, but it's okay. Thank you so much. Yeah, a negative deflection. Okay, does that make sense? Why? Can somebody tell me this case, which one it is here? Wait, let me just check one last time. A depolarization away from the positive. Okay. Can somebody tell me what case this is out of these four? You could say like
the
top
second one.
Which would
Top
be
right. Top right.
Top right. Perfect. Thank you so much. Exactly. Okay, top right. So a depolarization, positive charges moving away from the positive electrode. So that's positive away from positive, which is positive towards negative. So opposites, so it's negative. Perfect. Okay, now we can get to our leads. So this is I'm assuming, just based on my experience last year, I'm assuming that this is one of the more difficult concepts to grasp in this lecture. But inshallah, we'll be able to go through it sort of easily, sort of. So leads. So I mentioned that we have these electrodes that we put on our body when we want to do the ECG, right? When we want to measure the electrical activity, we have these little electrodes. Now, I don't want you guys to get confused. They're not like actual full magnets, voltmeters type of things that you see in physics. There are these little magnets. There's these little stickers that when you go to the nurse and they want to check your heart activity, they're going to put these little stickers all over your body, and they're going to be able to measure your electrical activity through the heart. So those electrodes, we can place them in different locations on our body to get a different view or angle of the heart. A lead is a graphical description of the electrical activity of the heart. Depending on the lead, we get a different view of the heart. We have 12 of these leads. What exactly does that mean? So do you guys see this little diagram? This little diagram that I showed. It's the same one that we've been using, just this time with a tiny little person looking in at the heart or through the heart at the negative electrode from the positive electrode. So they're looking at the heart from the positive electrode. So when we talk about leads and when we say that there are different angles of the heart, okay, we use the positive electrode as our angle of the heart. Okay, so for example, let's look at this lead. So we could see that the negative electrode's on the right side of the heart, okay, because we always, I don't know if you guys remember this from foundation, we'll always flip like this, okay, when we're looking at something. So the negative electrode is on the right side of the heart, and the positive electrode is on the left side of the heart. So when we're looking in, and I mentioned that a depolarization moving towards the positive electrode will create a positive deflection. So we can imagine a tiny little person standing at the positive deflection, looking in at the heart. If they see any positive charges coming towards them, they can record that as a positive deflection. Okay, so that's basically what a lead is. Now, it's not the only example I've showed you this so far is this example when we have the negative electrode on the right side and the positive electrode on the left side. But we actually have 12 of these views. So we've talked about depolarizations going this way, right? Again, I can't really point, so I'm going to have you guys just bear with me. We've talked about the depolarization moving this way, down from the negative electrode to the positive electrode, right? What about a depolarization moving diagonally this way? And if you guys know your anatomy, I'm going to describe it for you. What if we have a depolarization moving towards the apex of the heart? How would that look on an ECG? Can anybody tell me? It's not directly towards the positive electrode. It's going obliquely, it's going diagonally. Yes, excuse me, sorry.
So it's going to be small?
It's going to
positive.
be, yes, perfect. It's going to be positive, but it's not going to be as positive as this lead. Okay, so another way of looking at this would be this way. This is what I just described. Okay, so this is one lead, this is another lead. Okay, so a depolarized this time, so that using the same exact example that I used, a depolarization moving towards the apex of the heart. You guys said that it will be positive, just not that strong, just not a big positive deflection. What about now?
Strong positive deflection.
Small positive deflection? Are you sure?
Strong.
Oh, strong, sorry. Yeah, strong positive deflection. Exactly. And do you guys see why? It's because this time our depolarization wave, our positive charges are going directly to the positive electrode instead of diagonally to it or obliquely to it. So sometimes what will happen, and this is one of the questions that we had, not in our exam, but it was one of the questions in the practice books. But it's basically saying a patient comes in and they take his ECG, and then his mom checks the ECG, and she sees that not all of the leads look the same, so she worries and she thinks that there's something wrong with her son, right? Because not all the ECG traces, like for example, one lead, the ECG trace on lead 1, for example, looks different than lead 2, and she goes and she complains to the doctor, what's wrong with my son? His heart's showing up weird on the ECG, and the doctor tells her, well, that's fine. It's just different leads. It's a different angle. So just because you see a different shape of the ECG on one lead, it doesn't mean that there's anything abnormal. We're just looking at the heart from a different angle. Does that make sense to everyone? Okay, I'm gonna take that. Okay, perfect. I saw a thumbs up there. By the way, I'm sorry if you guys are sending in your chats. I can't really read them. So if somebody doesn't really want to unmute and somebody else would like to unmute and they see a chat, just please read it out to me. I can't really look at the chat right now. So do we have any chats, or are we all good to keep going?
You're good.
Okay, perfect. Thank you so much. Now, we said there are 12 leads. Let's start with the first 3. And these 3 should be the easiest to know. And I'm sure if you've studied this lecture, or at least paid attention in class to Dr. Simon, you guys should be able to know this. Let's start with the first 3, which are Einthoven's triangle. They're made up of 3 limb leads. These ones, we call them limb leads because we put the electrodes on our limbs. Okay. Lead one, we have the positive electrode on the left arm and the negative electrode on the right arm. Does that remind you of any other diagram that we've used? It's actually this one. This is lead 1. This is what lead 1 looks like. Our negative electrode's on the right shoulder, right? And our positive electrode is on the left shoulder or left arm. Okay, we say shoulders, we say arms, it's the same thing. They're on the left side of the heart. Okay, lead 2 has the positive electrode this time on the left leg and the negative electrode on the right arm. Okay, so does that remind you of anything, any other diagram that we've used? It's actually
the second one.
Yes, so this is lead 2. Perfect. This is lead 2. So with lead 2, would you say this is just like a little tiny question? Would you say that it records the electrical activity of the heart as it's moving to the left atrium or moving to the left ventricle? Ventricle. Yeah. Again, it's all about the different angles that you're using. So lead 2, we're looking in basically through the apex of the heart. Okay, so it's an inferior view because we're looking in from the left leg to the right shoulder through the heart. Does that make sense? because we're always looking in from the positive electrode. So if the positive electrode is on the left leg, we're looking in from the left leg at the negative electrode, which is our right shoulder, through the heart. So we're looking in through the heart in the direction of the right or of the negative electrode. I hope that that's not too confusing for you guys. Okay, finally, we have lead 3. Lead 3 has the positive electrode on the left leg and the negative electrode on the left arm. Okay, so this time we're still getting an inferior view, okay, but it's, instead of it being in this direction, which is lead 2, it's in the opposite direction for lead 3. Okay, so in lead 2, let's just reiterate, lead 2 has the positive electrode again also on the left leg, but this time we're looking up in the direction of the right shoulder, right? In the direction of the right shoulder. But in lead 3, we're looking still from the positive electrode, which is on the left leg, but this time in the direction of the left shoulder. Okay, so it's different views, both inferior views. Okay, so that's a Einthoven's triangle. Now, the next 3 leads are sort of just a tiny bit complicated, just a little bit. So instead of just jumping right into them, we're gonna build our way to understanding those three leads. So for that, I need you guys to just bear with me. I have a tiny little activity for you guys, and you're gonna have to participate. I'm sorry. Okay, actually, we're gonna talk about this first. So we're gonna talk about lead 2 first. So lead 2 is the most common, most popular, and generally the best view of the heart. So when you're looking at an ECG, especially in first year, most likely you'll be looking at an ECG or of a lead 2 ECG. And that's because it's an inferior aspect of the heart, but it's also because that's the way that normally our depolarization is heading, right? We mentioned that it's going down the interventricular septum, right? You guys remember that whole thing from SA node to AV node, and then down the interventricular septum, then up the walls of the Purkinje fibers, bundle of His, left and right bundle branches, all those stuff. Yeah, so it's moving in the direction of the left leg, right? So that's why we use lead 2 most commonly, because it usually provides the best view of the heart. Okay, now let's do our little activity. So this is, again, Einthoven's triangle. Okay, lead 1, lead 2, and lead 3. Now, let's do something. And you guys can't read the RA, stands for right arm. You guys can just follow along. Let's do something. Okay, actually, I'm going to have to switch this again. Can we move this to the bottom? Perfect. Okay. I don't know why I've been moving it across the top the entire time. Okay, so the important thing, the main thing that we need to remember, the main difference between Einthoven's triangle and the next 3 leads I'm going to talk about is the number of electrodes that we're using. In Einthoven's triangle, we call them limb leads, but we also call them bipolar leads. Bipolar leads because we're using 2 poles or 2 electrodes. Okay, one right one, or one positive one, and one negative one. Okay, in our next leads, in this practice, this little activity that we're going to do, we're going to take 2 electrodes and we're going to make them both negative. And we're going to have that signal feed into the positive electrode. Okay? So, do you guys remember from physics, if anybody took physics, do you guys remember that whole thing about vectors? You know, there's a left vector and a right vector, and then you find the net vector, which is like in the middle between left and right. You guys remember that?
And the resultant vector, you mean in physics?
Resultant, yes. Exactly, resultant vector. I stopped taking physics in grade 10. You know, I took it in grade 10, and then I hated it so much. I stopped for grade 11 and grade 12. It was just the worst for me. Unfortunately, this is a little bit of physics that comes into play in understanding this concept, but it's okay. I still remember some old stuff. So what we're going to do is we're going to take both of these negative electrodes and we're going to find the resultant negative electrode, or the net vector. Okay, so again, we always use the positive electrode as our angle of the heart. Okay, so if we're looking from the right arm, which as you see here is the positive electrode in this case, and we're looking down in the net direction of the negative electrode, where would that be? Do you guys know? I know that you can't really tell me. It's kind of hard to say, but it would be in the middle. If you take both of these lines, they look like this, and we just find the middle. It's going to be somewhere in the middle. It's going to look like this, and that's our first augmented lead. That's our AVR lead. Does that make sense? We're gonna now, as long as you understand this concept, everything else, inshallah, will be easy. All the other leads are super, super easy. This is just the toughest thing that you're gonna have to go through with this lecture. Does this concept make sense? It's very important.
May you repeat it?
Sure.
Can you repeat it, please?
Of course. I don't mind. So Einthoven's triangle. Now we're looking at Einthoven's triangle, okay? The main thing about the leads in Einthoven's triangle, as we see here, okay, is that we have two electrodes. So lead 1 in Einthoven's triangle has two electrodes, one positive and one negative. Lead 2, one positive and one negative. Lead 3, one positive and one negative. We're just placing them in different parts of the body. And thus we're getting a different view of the heart. But they all still use two electrodes only. But in these leads, in the augmented leads, what we're going to do is we're going to make it still one positive electrode. It's still one positive, but this time we're going to make it two negative electrodes. Okay? And remember that whole thing I said about vectors? We're going to use that, but then you might ask, okay, then you might say, okay, if we're using two negative electrodes, how are we going to be looking at through two different angles at once? You know, if we do this, how are we going to be looking in from the right arm to the left arm, and at the same time from the right arm to the left leg? We can't look at two places at once. We can't look at two things at once. You're right. What we're going to do is we're going to take the resultant vector, or basically the net direction of both of these negative terminals, and we're going to feed them into a single negative terminal, which is found right in the middle between them. So it all goes back to the resultant, the net vector idea from physics, you know, from high school physics. You know, so if we find the net or the average direction between both of these negative electrodes, we have a line going this way, right? Negative here to positive here, line going this way, and negative here to positive here, line going this way. So we have this line and we have this line. If we find the average between the both of them, or the middle, it'll be right in the middle between the both of them. And that's our AVR. R stands for right arm, as in the right arm is the positive electrode. Now, does it make slightly more sense?
Yes, but like I have a problem in understanding one concept. Why
Sure.
did the arrow goes from the heart to the right arm, not the other side? Because we're just getting the, you know.
Perfect. I'm actually so glad that you caught that. It's just there as it's just there as part of the diagram. Okay, they're just pointing to the right. But you are right, yes. And in this case, you're looking in from the right arm at the heart. You're not looking in from the heart at the right arm. I'm so glad you made this point because I really wanted to say this next. Thank you for that. Yes, you're looking in. So ignore this arrow. This is just there to show you the direction. Okay, but you're looking in the opposite way, from the right arm at the heart, from the right shoulder, like down the middle, in between the two negative terminals that you see in AVR. Okay, so just ignore the arrow. Ignore like where the arrow is pointing. It's the opposite way, like you said. Okay, from the right arm to the heart. Now does it make sense? Okay, I'm gonna take that as a yes and just hope that you guys are still with me. Okay, so now that we've done AVR, again, AVR, R is for right arm, as in the right arm is positive. And the two other limb leads, or two other limb electrodes, which are the left arm and the left leg, they're both negative. Okay, so if the right arm is positive and the left arm and left leg are positive, or negative, sorry, we're going to be looking in from the positive electrode into the resultant negative electrode, which will be in the middle, in between the both of these, right? And it'll give us this direction of the heart. Okay, moving on. Now that we've understood this concept, now we can apply that to the other two augmented leads. So same exact concept. This time it's the left arm. This time the left arm is positive, and the right arm and the left leg are negative. So do the same thing that we did. Take this line and take this line and find the middle, and point it up at the left arm, and that's our direction. AVL. Okay. Again, we're looking in from the left arm through the heart, or at the heart, in the direction of the negative electrode. And in this case, the negative electrode, since it's two electrodes, we find the net negative electrode. Okay, so basically both of these, like the physics behind it when it comes to the actual physical machine, you guys really don't need to know it, this far along. I really doubt that even, 50 years in interns have to know the exact mechanism of how this machine works. All you have to know is that you take both of these negative electrodes and you find the net vector, and then you point it up at the left arm, and that's your direction of AVL. I really hope that you guys are Still with me?
So we look at the heart from the positive side, like from where the arrow is meeting at the resultant vector, or do we see it from the heart side?
So we're looking in from the left arm at the heart, if that's what you're asking. We're not looking in. So the arrow again. I maybe this diagram was a bit of a mistake, because the arrow, I get that it's pointing up at the left arm, but no, try to imagine the arrow, this way. The arrow is just there to show you guys where the positive electrode is.
So like you mean like our eyes looking, our eyes like present at the left arm, positive side, and it's looking towards the heart.
Yes, exactly.
Okay. So basically looking at the left atrium.
Basically, yes. Basically looking at the left atrium. Now, technically it's through the left atrium. Sorry about that. Yeah, it's technically it's through the left atrium, because we're doing the electrical activity, right? But yes, it's exactly what you mean. If you're looking at it visually, yes, you're looking at the left atrium. So okay, what about here? Where would you be looking at? Right here, from an AVR.
Oh, the right atrium, but also like the posterior side.
Yeah, sure. Yeah, we could say right atrium too. Now, this stuff is just for your better understanding. Don't go into the exam and say, oh, Rawad said that the AVR, we're looking at the right atrium. No, it's just as there for you guys to get the visualization of it. Okay, so again, AVR, we're looking at from the right arm down at the heart in the direction of the resultant negative electrode in between the left arm and the left leg. And same thing with AVR. This time, it's from the left arm, and we're looking at the heart in the direction of the negative of the vector, or the net vector, or the resultant direction between the left leg and the right arm, which are both negative. And then finally, the easiest one to figure out is AVF. Now, I want one of you guys to help me out with this. So if we have our right arm and our left arm both negative, and our left leg is positive, using this diagram, which direction would we be looking at? Or where would we draw this?
Downwards.
The inferior septal.
Vertically downward.
Exactly. I'm so glad you guys are still with me. So yes, we're looking in from the inferior aspect, just straight inferior. Okay, that's AVF. It creates a vertical line, because that's the resultant vector between those two negative electrodes, our right arm and our left arm. Perfect. So this is the full image. We have lead 1, lead 2, lead 3 make up the Einthoven triangle, AVR, AVL, and AVF. Perfect. Okay, now let's actually talk about it. So the augmented leads. Our augmented leads are created by feeding, as I said, the electrical signal from 2 of the limb electrodes into the negative terminal of the ECG. Okay, our positive one is still there. Okay, our positive one is still 1 electrode, but our negative one is fed through two negative terminals, or 1 negative terminal from 2 negative leads. This creates a net negative electrode that lies in the middle between the 2 electrodes, and the third limb electrode becomes the positive terminal. Okay, so AVF, left foot at positive 90 degrees. Now, these little degrees, just ignore them just for the time being. We're going to be talking about them next. AVF, left foot at positive 90 degrees. AVR, right arm at negative 150. And AVL, left arm at negative 30. So we talked about 6 leads so far. The Einthoven triangle leads and the augmented leads. Lead 1, lead 2, lead 3, AVR, AVL, AVF. Can somebody tell me, oh, sorry. Okay, let's stick to these 6 for now. Can somebody tell me what we see in common between these 6? What okay, I'm going to put it in another way. There's a specific plane, anatomical plane, that we're looking through the heart from when we're using these 6 leads. Sorry? Frontal. Yes, frontal plane. Exactly. So imagine you cut the body in half this way, right? This way, you're separating anterior from posterior. That's the direction we're looking at the heart from. So when we say that we're looking from AVF, for example, we're looking through the bottom, through the posterior aspect of the heart. Not the posterior, the inferior aspect of the heart. Okay, through the heart in the frontal plane. Okay, now the next 6 leads are in an entirely different plane. Okay, these first 6 are in the frontal plane. Does anybody remember from your own lecture, from your own studying, what the next 6 record in? What plane?
What?
Precordial
Transverse.
Yeah, the
Transverse plane.
precordial transverse plane, exactly. So the first six, frontal plane, Einthoven triangle, leads 1, lead 2, lead 3, AVR, AVF, AVL, and the precordial leads, they record heart activity in the transverse plane. Okay? Now, what does precordial mean? Do you guys know? This is just for your information, just so that you won't have to memorize it. You could just understand it. You might notice I'm very, very big on understanding rather than memorizing. I'm not a great memorizer. So precordial just basically literally means in front of the heart. Okay, it's in front of the heart. Okay, so precordial leads, they record again in the transverse activity, are augmented. The augmented and bipolar leads record in the frontal or coronal plane. Okay, and our precordial leads, they record heart activity in the transverse plane. All of these leads are positive. That's the main thing about the precordial leads. Okay, and the augmented and the bipolar leads, we have either 2 negative electrodes or 1 negative electrode and 1 positive electrode. Okay, so but we always have a negative electrode there. These ones, they're all positive. All the leads are positive, and they use a common negative electrode that's located inside of the heart. It's very hard to visualize. I completely understand. But we look at the cortex of the heart, which is basically located inside of the heart. So they all feed into one negative terminal, and they look in this direction through the heart. Okay, this exact direction through the heart. Okay, the leads are placed in an arc starting from the right of the sternum and proceeding under the left arm. So can you guys see me, by the way? Because I'm gonna be just kind of showing it on myself. I want to make sure that I don't look stupid. Can you guys see me?
Yeah,
Perfect.
we can see you.
So at V1, we're going to call these leads V, by the way, V1 through 6. V1 on the right of the sternum, V2, V3, V4, V5, and V6. They record heart activity.
Could you
through the heart.
position yourself, the iPad a bit below? If we can.
Sure.
Yeah.
Sure. Now can you guys see me? Okay, so V1 on the right of the sternum through the heart in this direction. Okay, transversely. Lead 2, or sorry, not lead 2, V2, right, on the left of the sternum, right? And then you go in an arc, V3, V4, V5, and V6. Does that make sense to you?
Yeah.
That makes sense? Okay, perfect. So those are the precordial leads. Now, these ones, here's the best news that you're ever going to get in your entire life. These ones are sort of low yield for first year. Okay, you're not going to get too many questions about the precordial leads, most likely, especially since we had Dr. Simon too. I don't remember a single question that we got on the precordial leads. Great news. Okay, but there, again, it's just there for your better understanding of it. So, but the main thing you want to remember is that they record in the transverse plane and not in the frontal plane, as like the augmented and the Einthoven triangle leads. Does that make sense?
Yes.
Yep.
Yes,
Yes.
it's clear.
Okay, perfect. Now, summary. We have 12 leads in total, 3 bipolar leads, or again, bipolar because they use 2 poles, but we can call them also the leads of the Einthoven triangle, 3 augmented leads, and 6 precordial leads. The 3 bipolar leads, again, make up Einthoven triangle, leads 1, 2, and 3. Our augmented leads use 2 negative electrodes and 1 positive electrode, so they're AVR, AVF, and AVL. And the precordial leads are placed in front of the heart, and they record heart activity in the transverse plane, V1 through V6. Again, I mentioned this about AVR, but just I really want to reiterate. AVR, positive electrodes on the right arm. AVF, take F for foot, it's on the left leg, but take foot. It's just an easier way to remember it. AVF, the positive electrodes on the left foot, and the 2 other ones are negative, obviously. And AVL, can somebody tell me? Positive electrode on the...
Positive on the left left limb.
Left limb, yeah, left, not left atrium, left arm. Looking
you're
at...
asking. Oh, okay.
Yeah. Don't the left atrium thing was just for your guys' understanding.
Oh,
Okay, we're looking at like in which direction. We're not actually looking at the left atrium from AVL. Okay, but we're looking like in that general direction, you might say. Okay, perfect. Now we're gonna do another little activity. I'm sorry for this, but this one's just a little backstory to it. So we said again, this is by the way, we're gonna be doing an activity on the first 6 leads because I said precordial is not that high yield in first year. We're gonna be doing it on the first 6 leads, which are leads 1, 2, and 3, AVR, AVF, AVL. So what's the thing in common that we said about these 6 leads? The one thing in common between all 6 of them.
They have electrodes.
Yeah, but the other thing, which plane?
Frontal plane.
They are
Frontal.
transverse?
Not transverse. Transverse are precordial leads. I'm talking about the first 6, which are the bipolar leads 1, 2, and 3, and the augmented leads, AVF, AVR, AVL. They record in the frontal plane. Okay? So imagine you have a person standing in front of you, and you want to basically draw a circle around their hearts or around their body and place their heart in the very center of that circle. And then we're going to basically do some angles. We're going to put some angles on that circle. We're going to make it basically look sort of like the unit circle from math. This has nothing to do with the unit circle, by the way. It's just what it looks like. Okay? Now, left arm, if we draw that circle, the left arm, when it's compared to the right, when it's compared to the heart, let's say it's around the same level, we're going to put that as 0, just by convention. Okay, that angle, we're looking in from 0 degrees at the heart. Okay? Okay, so 0 degrees from the heart is where your left arm would be. 30 degrees, okay, obviously then you would have 30 degrees, so you could be looking in from that angle, 30 degrees from the heart. We're going, by the way, from segments of 30 degrees, so 0, then 30, then 60, 90, 120, 150, 180, and then we're going to do negative 150, negative 120, negative 90, negative 60, negative 30, and then back to 0. Okay, so basically, this you sort of just need to draw it out a lot of times to be able to understand it. Okay, but the whole point of this little thing that we did, this little circle that we did, the whole point of it is we know which direction, specifically which direction, which quantitative direction we're looking in at the heart from. Okay, so I can say, for example, that I'm looking at lead 2. I'm looking at lead 2. But then you might be asking, okay, which angle is lead 2? You can't always tell me it's from the left arm to the right arm. Right? You can't always say that. Or sorry, left leg to the right arm. You can't always say that. It's too wordy. So we're going to put a number on it. We're going to say I'm looking at blank degrees in the frontal plane. So a depolarization traveling blank degrees in the frontal plane. Okay? 0 being the left arm, 180 being the right arm. Okay? So that being said, if we look at lead 1, does anyone want to remind me where the electrodes are placed in lead 1?
Negative in the right limb and positive in...
Yes, in the left limb or the left arm. Perfect. So we're looking in, again, as you said, we're looking in from the left arm at the heart in the direction of the right arm. Which angle would that be? What angle is that
0.
on the frontal plane? Sorry?
0.
0, yes. Perfect. Thank you so much. 0. Okay, so lead 1, we're looking in 0 degrees in the frontal plane at the heart. Okay, or in other words, if we go back to the very first, one of the first things that I did. Wow, this is long. Yeah, okay. Actually, wait, let's move back just a little bit more. Right here. Okay, so positive electrodes, or sorry, not positive electrodes, depolarization, positive charges moving to the positive electrode. Okay, we could say that that's going to the positive electrode. It's going to create a positive deflection lead 1. And we can say that the depolarization is moving 0 degrees in the frontal plane because it's going to the left arm, which, if you look at this diagram, is 0 degrees in the frontal plane. 1 second. 0 degrees in the frontal plane. Does that make sense? I want to make sure we absolutely nail down this concept before we uncover the rest of these leads.
Yes, it makes sense.
Perfect. I'm so glad. Now, what about lead 2? Can somebody tell me what angle lead 2 is?
60 degrees.
60 degrees. Yes, perfect. 60 degrees. Okay, because we're looking in from the right arm to the left leg. And if you draw that line out, if you draw a line from your right arm to your left leg, it should match around 60 degrees. Okay? Does that make sense? By the way,
Yes.
we say left leg by convention. It doesn't mean that the electrode will actually be on your left leg. Sometimes they place it just below. It's because we say left leg to place it right under the heart. And we know that the heart is a little bit turned to the left. But it's inferior, it's right inferior to the heart. Okay, it's right underneath the heart. Okay, don't think that just because the diagram places the left leg in the center, centrally or like vertically down from the heart, inferior to the heart, doesn't mean that it's actually on your left leg. Okay, they just say that, but it's underneath your heart, it's inferior to your heart. Okay, perfect. Lead 2, 60 degrees in the frontal plane. What about lead 3?
120.
120. Perfect. You guys have got it pretty much. Mashallah. So now I think the next one is AVR, if I'm not mistaken. So AVR, what direction are
Negative
we looking?
150.
Yes, negative 150. Perfect. Negative 150 again, just to reiterate, because we're looking in from the right arm in the general direction between the left leg and the left arm, which are both your negative electrodes. In that direction, down this angle, we're looking in from negative 150 degrees in the frontal plane. Then we have AVL, left arm being the positive electrode.
Negative 30.
Negative 30. And finally, AVF. Perfect. Is every single person in this Zoom meeting, is everyone with me so far?
I understood the
Yes.
augmented leads, but then how is 1, 2, and 3 like at 0, 60, and 120?
Okay.
Because
yes.
earlier we mentioned that when we draw a resultant vector from the right arm and the left leg, basically we look at the right ventricle. So shouldn't it be like 150?
Well, no, because the example that you just gave me, we're looking at 2 negative electrodes, but in the bipolar leads, because you could tell from their name, bipolar, 2 poles, 2 electrodes, we're looking at just 1 negative electrode. So if we put the negative electrode on the right arm, khalas, like that's your negative electrode. It's right there. You're just looking at in a straight line. You're not looking into the resultant vector of anything because it's just 1 electrode. It's not 2. When you have 2, the whole point is that when you have 2 negative electrodes, you can't be looking at both of them at the same time. So you look at the net negative terminal, which is in between the both of them. But if it's just 1 positive and 1 negative, you're looking in, it's that simple, from the positive to the negative. From the left arm to the right arm in this direction, it's a straight line through the heart, 0 degrees in the frontal plane.
Oh, okay.
Yeah. Okay.
Thank you.
Perfect. Yeah, no worries. Okay. Again, so now that we've got all our all 12 of our leads down, now we're just going to be pinpointing, okay, like from this angle, from this lead, we're looking at this view of the heart. This one's this view. So the first one we're going to be talking about is your inferior view. Okay, inferior view, that's going to be leads 2, 3, and AVF, all in the frontal lead, in the frontal plane. Okay, so I drew these little eyes there to tell which direction we're looking at the heart from. So if we look at from lead 2, or 60 degrees in the frontal plane, 90 degrees in the frontal plane, or 120 degrees in the frontal plane, leads 2, 3, and AVF, they're all in the inferior view of the heart. We're looking in inferiorly through, or to the heart, at the heart, sorry. Does that make sense? Okay. Now, this inferior view, okay, basically the inferior side of the heart, okay, is supplied by the right coronary artery, specifically PIA. Now, this table is in a bigger form in your actual slides, right? Am I mistaken? Like it says inferior view, anterior view in your actual slides. There's a table. One of the, like I think it's one of the last slides, right? Somebody confirm. Yes. Yeah. Okay. That one, it says right coronary artery, right? That little table in the far right. The one for inferior view, it says RCA, which is right coronary. Now, I specified that it's PIA because usually PIA is coming from the right coronary artery. This is very important because we got an SAQ on this question exactly. Okay, we were talking about an inferior myocardial infarction, which is basically a heart attack in the inferior side of the heart. And they were asking what side or what artery specifically supplies this side inferiorly. And everybody answered right coronary artery because that's what was in the slides. But the answer was actually PIA. But right coronary artery is still somewhat true because PIA usually in right dominant cases comes from the right coronary artery. Okay, and it supplies. Do you guys know what it supplies? Just this little anatomy to throw in there. PIA, posterior interventricular artery. The posterior interventricular septum. That's what it supplies. Okay, so if there's a problem in PIA, there's a problem in PIA. There's going to be a problem in leads 2, 3, and AVF, because those are the ones that are looking inferiorly at the heart. Okay, does that make sense?
Yes, but like I have a question about like, the concept itself. Correct me if I'm wrong. I read in the PPT that the LAD, it's going through the apex like posteriorly. So I
Mhm.
think it's the artery that covers the inferior part.
Well, actually, LAD is going anteriorly. Now, do you guys remember that whole thing about the heart being positioned sort of like this? It's not just like straight down, it's a little bit angled up. You guys remember that? Did you guys learn about that yet in anatomy? So it's sort of turned. The heart in and of itself is not just sitting there, this is the right side, this is this is the right side, this is the left side, this is anterior, this post. It's sort of turned, sort of twisted. When you twist that, you're actually pushing the anterior section, or the basically what you're mentioning is that LAD is traveling also inferiorly. But since the heart is turned somewhat, it's turned a little bit, that angle is actually, the inferior angle is actually falling more on PIA and falling more on the ventricles rather than the inferior portion of the ventricles rather than the anterior, or the place where LAD's traveling. Does that make sense? Because it's
Yes.
turned somewhat. Yeah. So this has
Thank
to
you.
do more of the, yeah, no worries. This has to do more with the anatomy of the heart. And this is something that you guys will take more in detail, inshallah. But yeah, for right now, just know that leads 2, 3, and AVF, those are your inferior views of the heart. Okay. Next are the lateral views of the heart. Okay. Lateral, fairly simple. We're looking at left and AVL, left arm and AVL. Okay. And V5 and V6. Okay. Does that make sense?
Yes.
Okay, perfect. And again, it's left, it says LCX on your sides, and that's left circumflex arteries. Okay, and anterior view, we're looking at V3 and V4. Now, can somebody tell me why we're not looking at, for example, lead 2? It's sort of in the same direction, is it not? Like if we look at the diagrams, it's sort of in the same direction. Why is it not lead 2? Also in an anterior view.
Maybe because leads to is looking at the apex.
Yes, exactly.
Not,
Specifically,
yeah.
it's specifically because we're looking at the frontal plane. Exactly. We're not looking through the cross-sectional plane. The cross-sectional plane is where you're able to tell, okay, this is anterior, this is posterior. But the frontal plane, right, there is no anterior posterior. You're splitting it down the middle, right? So that's why our anterior view are the precordial, or specifically V3 and V4 in your precordial leads. Now, this is where we put LAD. This is the part where this is the artery supplying that specific view. LAD, left anterior descending artery. Okay, and finally, septal view, septum, V1 and V2, fairly simple. Okay, and again, I really want to iterate one last time. This is not that insanely high yield of a concept. Okay, maybe inferior view, but as I mentioned, anything with precordial in it, you'll likely won't take in detail. But it's good to know. Don't take what I say, word for word. Still study it. Still make sure you understand it. But just to better prepare yourself, they're mostly going to be asking about the augmented and the bipolar leads. So inferior view is probably your best bet. Best bet if they will ask any questions about this concept. Okay, because they did for our SAQ. Anyways, checkpoint number 2. This was sort of a big gap between the first and the second checkpoint. Do you have any questions up until now?
Yes. Why do we have 12 electrodes? I mean, 12.
I'm sorry, your voice cut off. Is it my internet? Your voice cut off at the very end. You're asking why do we have 12 electrodes and...
No, 12 leads, but 10 electrodes.
Because some of them, we have 12 leads, but 10 electrodes, because some of them, as I mentioned, in the augmented leads, 2 of them can be used as one electrode, or one, yeah, 2 of them can be used as one electrode. So if we're talking about, actually, well, the electrodes, yeah, you have 6 here, and you have 3 here, so it's actually 9. It's 9 actual electrodes. One on your left limb, one on your right limb, one on your left leg, and then the 6 precordial ones. Right? So, but again, we have 12 leads because AVR, AVF, and AVL use 2 electrodes as one electrode or one terminal of an electrode. Okay, so we're not just using not every single lead has only 2 electrodes. Some of them have 3. 3 of them have 3 specifically, the augmented ones. Does that make sense?
Yes, it does. Thank you.
Yeah, no worries. Okay, now that you guys were at the second checkpoint, I'm going to ask you your second pop quiz. A ventricular depolarization wave, when traveling 60 degrees in the frontal plane, will cause a large positive deflection in which of the following leads?
Is it D?
Two.
Yes. Yes, lead 2. Perfect. And that makes sense why, right? From the graph. Again, I don't want you to memorize it. Okay, if you feel the need to, and by the way, I did this in my actual final. I grabbed a piece of, that piece of paper that they give you when you're doing your final, that scratch piece of paper. I drew out this entire picture, like the picture that I showed you guys with the degrees and the angles and everything. And then every single time I wanted to use that, I'll just look back, I'll look back at it and I won't have to remember anything at all. Okay, so just draw the lines, label them 0, 30, 60, 90, 120, 50, so on, and then label, this is left arm, this is right arm, this is left leg, and then fill out the rest. And if you do that, you do that right now. If you guys after this past session, you guys just sit down and you draw that out 2 or 3 times, you'll have it memorized for the rest of your first year. I'll just say first year, just in case you guys remember it in second year. Okay. Now let's talk about the actual ECG. Okay, sequence of events. Sneak peek. This is what the ECG looks like. Okay. Now I know that the concept, or sorry, the title of this lecture is ECG, but ECG is hardly the most, the actual ECG is hardly the most difficult concept in this lecture. The hardest ones were probably the precordial leads and not the precordial, sorry, the augmented leads and all that stuff. This stuff is fairly simple. As long as you know the electrophysiology of the heart, as long as you know the path, the conduction pathway through the heart, you should know the ECG really, really well with no problems. Let's get started. Let's do a little recap. The action potential in a healthy heart, healthy person, propagates from the SA node, the sinoatrial node, and depolarizes the atria first through the intraatrial pathways. Okay? Or Bachman's bundles, they call them. You guys don't have to know that. They depolarize the atria first. The action potential then spreads to the AV node, the atrioventricular node, where it experiences a short delay to allow for further ventricular filling. Then it travels down the bundle of His. You'll see everything is labeled on this diagram. It travels down the bundle of His and the left and right bundle branches. And then it travels up the walls of the ventricles through the Purkinje fibers and causes ventricular depolarization. This is just a recap of your previous lecture, electrophysiology of the heart. Does anybody have any issues with this concept before we move on? Because this is a very, very crucial concept to know when we're talking about the ECG. So anything you're unsure about, anything you're nervous about when it comes to this concept?
No, it's fine. Carry on.
Perfect. Okay, let's start with the very first thing on the ECG, which is the P wave. Okay, so that's this tiny little wave that you see at the beginning of the ECG. The P wave, sorry, I told you I'm going to keep doing that. The P wave results from a wave of depolarization originating from the SA node and then spreading to the AV node. It causes a positive deflection on the lead 2 ECG since the depolarization is heading in the direction of the positive electrode. Once the entirety of the atria is depolarized, the action potential continues its journey through the AV node. Okay, we read that slide. We've got everything that we need. Now let's actually explain it. So the SA node, once you have an action potential that propagates from any certain area, any certain point, it's not going to move in just one direction. It's not going to go, I'm going to go left, I'm going to go right, I'm going to go down. No, it's going to move in every single direction. It's a wave. It's going to propagate from the entire SA node. Okay? But remember that concept about the net vectors, about the net, whatever, the net direction. Okay? Yeah, so we remember that. Now, subhanAllah, when we have these action potentials that are propagating from the SA node, the vector of them, which is the net direction of them, will be right in the direction of the AV node. So do you guys look at the diagram? You guys look at the diagram, the SA node, the action potential is propagating from the SA node in every direction. But the net direction is going to the AV node. Okay, now this is lead 2, right? This is a lead 2 ECG. I mentioned that when we're talking about a normal ECG, usually we're looking at lead 2. Okay, so imagine that this is a lead 2 ECG. So negative electrode, again, on the right arm, right shoulder, right limb, whatever. Left, or sorry, no, did I say, no, I meant negative electrode, sorry. Negative electrode on the right arm, positive electrode on the left leg. Okay, so if we have an action potential that's propagating from the SA node in the general direction towards the AV node, will that cause a positive or a negative deflection on the ECG? Depolarization.
Positive.
Positive. Effect. Yes, because it's going right in that direction. It's going right in the positive, right in the direction of the positive electrode. That's going to cause a positive deflection, and that's what the P wave is. P wave, atrial contraction. That's what it is. It's the action potential that's propagating from the SA node. First, it's going to depolarize the entire atria, and then it's going to move to the AV node. So your P wave is your atrial contraction. Okay? So then I said, the next thing that's going to happen, then the next thing that you have is your PR interval or your PR segments. Okay? Now, I want you guys to sort of really, really remember this next point. A segment is an isoelectric line. Okay? And an interval is the isoelectric line plus the activity that precedes it or follows it. And okay, do you guys see those little tiny, those flat lines on the ECG? Right after the P wave, there's a little flat line. Nothing's happening in that line. That's called a segment. Okay, but if we take a line, if we take a portion of the ECG, starting from right before the start of the P wave until the end of that flat line, then that's called an interval because it includes an activity. It includes any deflection, whether positive or negative. So an interval is an isoelectric line plus an activity. A segment is just the line. It's just the isoelectric line. So I'm talking about right now, I'm talking about the PR segments. So I'm talking about only the isoelectric line right after the P wave. Now, this is a period of electrical neutrality, which is why it's isoelectric, because the P waves, or sorry, the action potential is not going anywhere. And it follows the P wave, it's called the PR segment. The PR segment is the time it takes for the action potential to be conducted through the AV node. Recall the slight delay. Okay, do you guys remember here that I talked about the AP spreads to the AV node where it experiences a short delay to allow for further ventricular filling, right? That's exactly what we see on the ECG. Okay, so after the action potential, we're still going through in the sequence of events. After we go from the SA node down to the AV node, and your action potential is at your AV node, the AV node is going to say, well, hold on, I want to hold on to some of these charges before I let them go. I'm going to hold on to them just for a tiny bit. Specifically, I think it's like 0.1 seconds, or even less maybe. I think it was 0.08 to 0.1.2, or 0.12 if I'm not mistaken. Anyways, it holds on to these charges just for a little bit to allow for further ventricular filling. Otherwise, do you guys know the whole thing about the heart where the atria pump before the ventricles? So it was like boom, 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 right? That's because of this short delay in the AV node. Otherwise, you would have both of them contracting at the same time. You don't want that happening. That's why the AV node is there. It's saying, wait, hold on, wait just a second, allow for the atria to pump first, and then I'll let you go. That's what the AV node is doing. While the charges are there, they're not going anywhere. They're just being held onto. So is there any electrical activity taking place during this little segment? None at all. And that's why we have an isoelectric line, isoelectric portion on the ECG right after the P wave. We call that the PR segments. Does that make sense?
Yep.
Yes.
Okay,
Yeah.
perfect. Okay, next, your QRS complex, and specifically, we're going to be talking about the Q deflection. Now, this is actually, I don't know why, to be honest, maybe it's just me being weird. This is my favorite part of the ECG. It's just such an interesting concept. And every single time I study it, it's so interesting. Anyways, once the action potential is conducted through the AV node, it goes through a series of steps that depolarize the ventricles. Now, the ventricles are big. The ventricles are really, really big. They're the big part of the heart. It's going to take a few steps to depolarize it. It's not like the atria where you just send an action potential. It's not like with the atria where you go like, I want to send an action potential this way, and boom, the atria both are depolarized. No, you have to put in a little bit of effort when it comes to the ventricles. So there's a series of steps. The first one's called the Q deflection. Now, we've stopped at the AV node. We've experienced that short delay. Now we want to get moving. We're going to travel down into the bundle of His, which is just that little starting path right after the AV node, and then down the left and right bundle branches. They're labeled on the diagram if you guys have any confusion about them. Okay, so AV node to the bundle of His, down the left and right bundle branches. Now, once we're at the left and right bundle branches, we need to also depolarize the interventricular septum. Okay, because we want to depolarize the entire heart. We don't want to say, like, basically the action potential are traveling now. They're traveling down the left and right bundle branches, and then they look to their side and they see the interventricular septum, and they go like, well, now we have to depolarize that too. So some charges have to go, in the direction of the interventricular septum itself, and not just down the septum, but into the septum itself. So to depolarize that portion too. Do you guys think, now this is a little bit of a difficult question, but I'm going to ask it anyways. Based on the Q deflection, if you guys take a look at the Q deflection, which comes right after the PR segment, you'll notice that it's a slightly negative deflection. Slightly negative, just a little bit negative. And we said that it comes from interventricular septum depolarization. Where do you guys think these charges are coming from? Are they coming from the left bundle branches or the right bundle branches?
From the left.
From the left bundle branches. MashaAllah, you sound like you've studied this already a few times. Yes, the left bundle branches. Okay, and when we have depolarization or charges coming from the left bundle branches, depolarizing the interventricular septum, if you look at the diagram on the top, they're going to be traveling away from the positive electrode on lead 2, right? They're going to be traveling away from the positive electron on lead 2, and thus they're going to be giving us a small negative deflection. And that's because, again, positive charges for deflection, for depolarization, positive away from positive, or again, positive sort of towards negative, not fully towards negative, but all we care about is that it's away from the positive, and that's going to give us a negative deflection. Okay, does that make sense? That's why we have Q deflection, which is a negative deflection. It results again from the depolarization of the interventricular septum from the left bundle branch. Oh, I forgot that you could just see. I forgot that you could just see the answer right there. Forgot about that. Yeah, does that make sense?
I have a question. You said that it goes from toward the left ventricle. It's away from the positive charge, right?
It's away from the positive electrode, yes.
Yes. How that come in the left, or yes, the left bundle branch go, يعني it supplies the ventricle as a whole, so it must go to the left side, and the right also in the same way. So.
Oh, okay. So I see what you're saying. Because we're depolarizing the ventricles. Well, actually, the ventricles themselves, okay, that being the walls of the ventricles from the outside, those aren't depolarized just yet. So this is right before those walls, the ones that you're talking about, the left and right ventricles, those are before they're depolarized. Right now, we're still traveling down this interventricular septum. We haven't made our way to depolarize the outside walls of the ventricles yet. We're still in that little tiny spot. We haven't moved all the way down. Now, I want you to keep in mind the QRS complex, it all takes place within 0.1 seconds. Okay, so it all happens very, 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 very quickly. Okay, so that's why we just call it ventricular depolarization. But there's actually more that's going on if you dig deep into the actual ECG. Q deflection is specifically interventricular depolarization because we haven't made our way down the left and right bundle branches yet. We haven't made it all the way around. Okay, does that make sense? Now, if you want to ask me why did they come from the left bundle branches, not the right, we don't know. That's just the way it happens. They just happen to come from the left bundle branches, and that's why it's a negative deflection.
No, okay. Another question. In the image you're showing, you have the positive electrode down and the negative electrode up. Okay, we said depolarization, when it goes to the positive electrode, it's a positive deflection. Okay, yes. So actually our action potential, it's going from the SA node down toward the positive electrode. So I
Yes.
think this should be like a positive
Yes.
deflection.
Yeah. Yes, you're right. You're right. You're right. And it will give us a positive deflection. But just for the specific portion of the ECG, just for the specific portion, if you take a look at the bottom diagram, you'll see that the P wave is a positive deflection because it's from the SA node to the AV node, which is in the direction of the positive electrode. Okay, but the Q deflection, because it's just in that little tiny portion on the ECG, we're just depolarizing the intraventricular septum, and it's going in that direction. That's why we get a negative deflection. Okay, but the overall activity is traveling. Yes, it's traveling towards the positive electrode overall. But within the ECG itself, there's going to be some deflections, some negative deflections, just when we have that intraventricular depolarization, because they're coming from the left bundle branches in to the intraventricular septum and sort of away from the positive electrode. So yes, you are right in thinking that it's generally like it's the charges are going down in the direction of the positive electrode, yes. But if you take a look, if you dig deep, there are a few negative deflections in there, just when we're depolarizing different parts of the heart.
Okay, thank you.
Okay, no worries. Okay,
somebody
next.
asked in the chat, is it traveling perpendicular to positive electrode?
Perpendicular? No, not quite perpendicular. Okay, no, the way I drew it, the way I put these charges, the way I put these charges on here might not be perfect, but it's technically not perpendicular. If it was perpendicular to the negative electrode, then it would be, again, an isoelectric line, because it would be electrical neutrality. So you wouldn't say perpendicular, you would just say intraventricular septum depolarization. On the exam, they're not going to be asking you, away from, towards, the away from. They're just going to say, what is the Q deflection on the ECG? You're going to tell them it's intraventricular depolarization. Okay? So the way I drew it might not have been perfect, the way I put the electrodes, but it is not perpendicular. And nor do you have to know specifically, is it, left or right, or you don't have to know any of that stuff. All good?
Yes.
Yep.
Perfect,
Yes.
perfect. Okay, next, the R wave. Okay, let's just go through it one last time. SA node to AV node, P wave. AV node holds on to those charges, PR segments. Okay, AV node down the bundle of hairs, down the left and right bundle branches, depolarizes the intraventricular septum, Q deflection. Now, we've reached the bottom of the left and right bundle branches. What will happen next? That's the little hints. You see this? What's the next fiber that the axial potentials travel through?
Purkinje fibers?
Purkinje.
Purkinje fibers, yes. And if you look at the diagram, those are going up the walls of the ventricles. So if we have an axial potential that's moving down the intraventricular septum, and then it's moving back up, so it goes down and then back up through the Purkinje fibers, and it's a depolarization, and it's moving up away from, if you look at the diagram, away from the positive electron. Oh, sorry about that. No, I'm sorry. I skipped something completely. My bad, guys. No, I skipped something. I skipped the actual depolarization of both ventricles. Okay, before we get to the Purkinje fibers, okay, the axial potential travels the left and right bundle branches, depolarizes the intraventricular septum, and it continues down the left and right bundle branches. Okay? So as it's going down, still going down the left and right bundle branches, it's going to depolarize a little bit of the intraventricular septum, and then it's going to keep moving down. Now, what direction is that moving down to? Towards the
Apex.
Towards the apex, yes, and towards the positive electrode. Okay, but then you might say, well, actually, it's the left and right bundle branches, so they're not moving, directly in the direction of the positive electrode. But again, it's about the nets. It's about the net charges. Okay, so the charges, as they're moving down and they're depolarizing the ventricle, they're depolarizing the apex of the heart. So that wall of the ventricle, it's going to be moving again in all sorts of directions. But what did we say about the left ventricle from anatomy? You guys remember anatomy? What's so specific about the left ventricle as opposed to the right?
It pumps blood to the whole body.
Yes, and because of that, it's a lot more muscular. That's the word I was looking for. It's a lot more muscular. The walls are a lot thicker. So which one do you think would need more of that charge, more of that little impulse to contract? The left or right?
The left.
Left. So it's going to steal more of those charges. It's going to steal those charges away from the right. It's going to take more electrical activity to pump the left ventricle rather than the right, because the left is just more muscular. So it's going to have to pump harder than the right. That's why when we look at the ECG, we see that the net direction of the action potential is going down the left ventricle specifically, just the net direction towards the positive electrode. And that's what gives you the R wave, which is a very, very, very positive deflection. Like almost vertical. It's such a strong positive deflection because it's going in the exact direction of the positive electrode, which happens to be on your left leg because we're looking at lead 2. Okay. I think I'm gonna start moving through it a bit fast because we're taking a bit too long. We still have a bit to get through. So the net vector of electricity is traveling to the left ventricle and therefore towards the positive electrode. That's your R wave. This is what I was talking about right before. The S wave. Okay, after traveling down the left and right bundle branches and depolarizing the intraventricular septum and depolarizing the ventricle or the apex of the heart, then it's going to go back up and depolarize the walls of the ventricles through the Purkinje fibers. So if we're going down the intraventricular septum, down the left and right bundle branches, and then back up to depolarize the walls of the ventricles through the Purkinje fibers, which way are we going? We're going back up.
Toward the negative?
Towards the negative. Will that give you a depolarization towards the negative? It will give you a negative direction or a negative deflection. This, of course, is a depolarization away from the positive electrode, producing a negative deflection on the ECG. Okay? So far we talked about P, which is the atrial contraction from SA node to AV node. We talked about the PR segment, which is the charges being held in the AV node, just for that little short delay. Then we talked about the Q deflection. The Q deflection happening to be the depolarization of the intraventricular septum. Then we talked about the R wave, which is the depolarization of the apex of the heart, down the left and right bundle branches. And then we talked about more depolarization of the ventricles as they're going up the Purkinje fibers, which is going to create the S wave, a negative deflection. Okay, then we have the ST segment. Okay, the ST segment, I didn't put it into a slide just because it's a very easy concept. It's just when both of your all of your ventricles are depolarized. Both ventricles are depolarized. That's your ST segment. Okay, so before they repolarize, they're going to stay contracted just for a tiny second, just for a little bit, just to pump the blood, because they can't just depolarize and then repolarize in the exact same second. So the ST segment is just the portion where they're both depolarized still. And then you have the T wave. Okay, so as we mentioned, like charges moving towards the like electrode will create a positive deflection. As the ventricles repolarize happen to be which charges, by the way? Are they positive or negative? Repolarization.
Negative.
Negative. They're negative charges. As the ventricles repolarize, which means they're becoming more negative, their negative charges begin moving away from the positive electrode and towards the negative electrode, which will give you the final positive deflection this time. So T wave. This. Okay. Technically, when you look at your slides, I think, correct me if I'm wrong, they mentioned that it's going from epicardium to endocardium, right? Your repolarization.
Yes.
Yes.
Yeah, right. That's the direction in which it's going. It's going cross-sectionally through the heart. Okay. But just remember that it's moving away from the positive electrode, which is why it's going to give you a positive deflection. Okay, but just remember also the repolarization is going from epicardium to endocardium. That's more of an anatomy concept rather than physio. All you have to know for this lecture is that it's moving away from the positive electrode, which will give you a positive deflection because it's negative towards negative. Repolarization, towards or away from the positive electrode and towards the negative electrode. Okay. So this is the final look at the heart. So you guys, wait, let me go back. So, right, you see the P wave, that's atrial contraction, then the AV node that holds onto it. Then it's moving down the intraventricular septum, depolarizing this, polarizing the heart, then depolarizing the walls of the ventricles. I'm speaking too slow, by the way. And then it repolarizes. Do you guys see that repolarization? right? I'll let that play one last time for you guys, just in case you want to grab a full picture, right? So the AV node, down the bundle of His, left and right bundle branches, then up the walls of the Purkinje fibers, and then repolarization. Okay. Now this happens, every single time your heart beats, this exact thing happens. Inshallah, if you have a healthy heart, this is what should happen. Checkpoint number 3. The last concept is fairly easy. It shouldn't take too long, inshallah. Does anybody have any questions for me so far?
No.
Perfect. Okay, pop quiz. Which mechanical event causes the Q deflection on an ECG trace? Q deflection. You guys remember P, Q, R, S, T. Sorry?
B.
B. Yes. Perfect. B. Depolarization of the interventricular septum. Now, okay, here's a little tiny pop quiz since you guys are with me. What would cause conduction of the action potential through the AV node? A. What would cause option number A? Or what would that cause on the ECG?
The
What would that
spread
be?
of action from the SE node?
Through the AV node. No, I
Yes,
mean, which segment is it on an ECG? Is it the T wave or the PR segment, Q deflection, R
PR
wave, S
segment.
wave?
PR.
Segment.
PR.
Yes, PR segment. That's the conduction of the action potential through the AV node because it's a slow conduction time, right? Or it's a slow conductor of the electrical activity. It's the PR segment. What about C, depolarization of the atria?
P wave.
P wave.
P wave. Yes, P wave. And D, repolarization of the ventricles, repolarization.
Q wave.
T wave.
P wave. Yes. Now, final thing. What would cause the depolarization of the ventricles?
QRS.
Yes, perfect. QRS complex as a whole. So when we're asked that question, we don't say, oh, the R segment the R wave or the S wave or the Q deflection. We just say the QRS complex because all of those steps together are depolarizing the entirety of the ventricles. Okay, perfect. Finally, heart rates. Okay, now Shams is going to talk a little bit more about this in her upcoming lecture, which is ECG part 2, the arrhythmias. Okay, but we'll just quickly talk about heart rates. Okay, so to measure it, we're going to look at the vertical axis of this. This is an ECG trace paper. Okay, if we look at the vertical lines, not the horizontal, the horizontal ones, not the vertical ones. Each big box is 0.2 seconds, and each big box is made up of 5 smaller boxes. Each smaller box is 0.04 seconds. Again, when we're looking at an ECG, the trace paper, the horizontal axis is the time, and the vertical axis is the voltage. Okay, I'm here to talk about the time section. Voltage is related more to arrhythmias. Okay, so one big box. Do you guys see the bolded boxes, not the small ones, the big boxes on the trace paper? That's one big box. Each one big box is 0.4 seconds, 0.2 seconds. And each smaller box within that bigger box is 0.04 seconds each. And there's 5 big boxes. So 5 small boxes. So 0.04 times 5, they add up to 0.2 seconds. Okay? So the heart rate, the heartbeat is the time it takes between each QRS complex. Okay, so the time it takes between each QRS complex, that's how long it takes for your heart to beat once. Okay, now to measure the heart rate, there's 2 ways to do it. Either you could divide 60 seconds or you could divide 60 by the time between the 2 heartbeats. So what you could do is you could count each single box in between each, for example, each R wave. You could count each box and then divide 60 by that time. So if we count do you guys see the R and R, that green arrow on the diagram? How many big boxes is that? 1, 2, 3, 4. There are 4 big boxes, and we said one big box is how much time?
0.2.
So what's 4 boxes going to be? How long is
0.8.
0.8. So we divide 60 by 0.8, and that's how we get the heart rate, which is 75 beats per minute. Or what we could do, there's two ways to do it. Or you could divide 300 by the number of big boxes, not the time, but the number of big boxes. How many big boxes did we say there are? 4. So 300 divided by 4, also 75. Okay, does that make sense? So two ways you could do it. You could choose whichever one you want. I personally did the I did the 300 divided by, because it's easier. And if it's like a number in between, if it's not exactly 4 big boxes, then you could do like 4.2, 4.4, 4.6, 4.8, 4. Or like 5. 4.300 divided by 4 point whatever it is, right? That's the personally what I used. You could use the first method if you want. It's up to you. Okay. Now there's three basically sinus rhythms that we're going to be looking about. By the way, sinus, the word sinus means, I'm sure you guys have heard it. Can anybody tell me what sinus means? I don't know if you guys have no, you definitely have, because you did ECG too, arrhythmias. Somebody tell me what sinus means. Okay, no worries. So sinus, when we say sinus rhythm, that's a rhythm, that's an action potential that's originating from the SA node, right? Sinoatrial node, sinus rhythm, originating from the sinoatrial node. As you know from your previous lecture, I think it might have been electrophysiology of the heart. The AV node is actually also a pacemaker. So the SA node is a pacemaker, is the pacemaker of the heart. But the AV node is also a pacemaker of the heart also, but it's just a lot slower. So if the SA node is not working, the AV node is going to be propagating all those action potentials, but they're just going to be slower than 60 beats per minute. Okay, so that's that one. We wouldn't call it sinus rhythm, because it's not coming from the SA node, it's coming from the AV node. Okay, so normal sinus rhythm should be between 60 to 100 beats per minute. Anything within that range is perfectly normal. So this one was a normal sinus rhythm, because it was 75 beats per minute, which is in between 60 to 100. Sinus bradycardia is less than 60 beats per minute. Okay, so you could try maybe later on your own time, if you would like to go back and read through these slides. You could try to measure out the heart rate, in that second ECG trace, if you would like to. And it should be less than 60 beats per minute. Okay, so that's sinus bradycardia. Brady means slow, cardia means heart rate or heart. So slow heart, bradycardia. Sinus bradycardia. It's a slow heart rate, originating from the SA node. And finally, tachycardia. Tachy means fast, cardia again means heart rate. Sinus tachycardia, more than 100 beats per minute. Okay, fairly simple concept. Now, the last little practice that we're going to do. Let's calculate the heart rate, and then look at what type of rhythm is this out of these three. Would you guys, by the way, it's been an hour and a half. It's up to you guys if you would like to do this. Who would like to do this activity, like themselves?
May I?
Okay, perfect. We'll give you a few minutes then. Take your time. You could use both methods, by the way. And one last thing, those boxes that you see, those are big boxes. Okay, they're not small boxes. We're kind of zooming out a little bit. So take each box as a big box, not a small box.
Actually, I think I'm done.
Okay. Can you tell me? Let me just check really quick.
It's 100 beat per minute.
100?
Yes, 3
Perfect.
big boxes.
Yes, perfect. It is 100 beats per minute. Perfect. So let's do this step by step. Let's focus on one lead, because if it's a normal heart, and actually most of the time it will be this case, the heartbeat in every single lead will be the exact same, the heartbeat. Because again, it's just different angles that we're looking at from. The same heartbeat is there, because it's, the heart's pumping very, very quickly. All of it pumps in a very short period of time. So the heartbeat is the same. The heart rate, sorry, I keep saying heartbeat instead of heart rate. The heart rate is the same in every single lead. So let's focus on one lead. Let's do lead 2, the one at the bottom, just because it's the one we're most familiar with. Then we're going to count the number of big boxes between each peak, which between each R wave, 1, 2, 3. Then we're going to calculate the time between each heartbeat. Okay, or by the way, I use the first method. You could also use the first method, doesn't matter. We're going to calculate the time. So 3 big boxes, that's 0.6 seconds. So 0.6 seconds between each heartbeat. And then we're going to calculate the heart rate, which is 60 seconds per minute. 60 divided by 0.6, which will give us 100 beats per minute. And what type of rhythm is this? It is sinus tachycardia. Or more specifically, it's just right on the border. Right on the border. But this would still be too fast, 100 beats per minute. So it's just on the border between normal and tachycardic. But we're just going to say that it's sinus tachycardia. Okay?
Isn't a normal heartbeat from 60 to 100? So why?
Yeah. So, this is just borderline. It's just borderline. This is just for some better practice. Okay, they're not gonna give you 100 beats per minute. They're gonna give you like something like 150, and that's obviously tachycardia, or something like 40, and 40 is obviously bradycardia. This is just in terms of this practice session. Okay. Thank you guys for bearing with me, and that's it from my part. Could you please do me a big favor and scan this code just to help out our wonderful subheads of the academics team under GND?